Today's session, we're going to be focusing on Bright Future guidelines, specifically looking at screening and preventative care considerations in children with medical complexity during the COVID-19 pandemic. Our guest faculty is Dr. Stacy Ellen. Dr. Ellen is an associate professor of clinical pediatrics at Drexel University College of Medicine and an attending pediatrician at St. Christopher's Hospital for Children. In Philadelphia, Dr. Ellen cares for patients in the Center for Child and Adolescent Health and the Center for Children and Youth with Special Healthcare Needs. Dr. Ellen serves as a post-clerkship director and pediatric pathway director for DUCOM and primary care pathway director for the pediatric residency program at SCHC. She is a current member of the Bright Future Steering Committee. Stacy, I'm going to turn it over to you.
Good morning, everyone. I'm really happy to be here this morning and thank you for having me. I do not have any disclosures. Today, we're going to outline Bright Future's guidelines and how they are used to support CMC and their families. We will name and review screening tools and guidelines related to developmental oral health, mental health, and immunizations. So according to a CMS report, preliminary data from September 2020 revealed that during the first half of the pandemic, primary preventive and mental health services have declined for children, including but not limited to vaccinations, developmental screening, oral health, and mental health services. Service delivery by telehealth has been occurring, but and in an increased rate, but not enough to offset the decline in services above. A little bit about Bright Futures in case you're not as familiar with it. The mission of Bright Futures is to promote and improve the health and education and well-being of infants, children, adolescents, families, and communities within the medical home. Bright Futures works with states to make the approach standard for the care of infants, children, and adolescents, help healthcare professionals shift their thinking into prevention-based, family-focused, and developmentally oriented, foster partnerships, and empower families with the skills and knowledge to be active participants in the healthy development of their children. Bright Futures is a set of principles and strategies and tools. They're theory-based, evidence-driven, systems-oriented. Addresses current and emerging health promotion needs, clinical practice, community, family health, and policy levels. And there's a link to Bright Futures in that slide. In addition to clinicians, Bright Futures contains relevant information, tools, and resources for a variety of audiences, which is particularly apropos for our audience today to remember that Bright Futures is really for all people in positions working with our children and youth. There have been 4 editions to date of Bright Futures, the most recent published in 2017. And the second edition of the Bright Futures Tool and Resource Kit, which will be listed at the end of this talk in terms of resources, was published in 2018. The 4 new topics highlighted in the 4th edition include the following, and I would like to note that one of them is promoting the health for children and youth with special health care needs. So not only is this promotion of health for children and youth with special health care needs its own chapter now, but there are also sections in every other portion of the book highlighting children and youth with special health care needs. A reminder of what Bright Futures is versus what the periodicity schedule is. So the periodicity schedule is what you need to do in the well visits in terms of when do you need to screen for X, how often do you need to screen for Y, etc. And I am aware it is in very small print, but we do have a link here for it. And I just want to note that the evidence and rationale and explanation, etc., for each of the portions of the periodicity schedule is below. You can see a number of links. That is not all inclusive. When you go to the AAP, there is a second page with additional links, and each category in the column in the white column with black text on the left has an appropriate superscript with the number 2 reference. So periodicity schedule tells you what to do and when to do it, and Bright Futures tells you how to do it and tells you how to do it well. And then just another view on the next slide of the periodicity schedule larger. But it talks about when to screen for normal growth, how to screen for normal growth in terms of what you're screening for, developmental screening, lead and hemoglobin screening, autism spectrum specific developmental screening, substance use and abuse screening, mental health screening, oral health screening, different laboratory type screenings, etc. I just want to make a note that everything that is in Bright Futures and the periodicity schedule, but specifically Bright Futures, there's evidence and rationale to support each of the recommendations. So there is an evidence and rationale chapter that I would encourage you to look at when you're thinking about why do we recommend X at time point Y, and think about how the recommendations came about and what studies were used in support. Particularly of note for this talk, the links to the recommended screening at specific Bright Futures visit are on this slide, both in the photos of the screening list and at brightfutures.aap.org. And Kathy from Bright Futures has also included a link in the chat, it looks like. The STAR Center, Screening Technical Assistance and Resource Center, also includes these tools. So now we're going to get into the meat of the talk today. There are 4 screening areas that I was asked to comment on in terms of special considerations for children with medical complexity during the COVID-19 pandemic. First, when we think about developmental screening, so Bright Futures and the AAP ask us to do developmental screening, which is different than developmental surveillance, which we're doing at every well visit. The developmental screening with the use of approved tools at the 9-month visit and the 24 to 30 months for general developmental screening. And then at 18 and 24 months for autism specific screening. So when you think about COVID-19 and CMC population, we think a lot about care delays and people being off cycle for their visits. So for example, if a child had turned 12 months last March and, or let's say 15 months last March, and the clinic decided that they were only having visits where there were cohorted vaccines, or the family was too nervous to come in, then they may have become off cycle. And let's say then they may be presented at 19 months for a 15-month visit and then 22 months for an 18-month visit. Then what screening tools do you utilize at that time? So you have to think about when the screening tools are validated. In terms of the autism specific tools, the MCHAT is validated from 16 to 30 months. So if a child presents at 22 months and it's a delayed 18-month visit, you absolutely can give the MCHAT as a tool. This SWIC, which is and I'm not endorsing any specific tool, but I will be commenting on commonly used ones. The SWIC actually happens to have the POSI on it. The POSI is the parents' observations of social interactions. That is a small autism specific screening tool as well. So that can be used in this time frame. But what happens if a 33-month-old presents for a 24-month visit or even a 30-month visit, but they've never had autism-specific screening, or they haven't had their second autism-specific screening? What do you do? Well, in this case, there are other tools that you can use. For example, the SWIC that I just mentioned, since the MCHAT is validated through 30 months. And we happen to use the MCHAT R in our clinic. And sorry, I'm using alphabet soup, so I just want to make sure you know what the MCHAT is, which is the modified checklist for autism in toddlers, and the R means revised, so it's the 2nd edition. When we think about administering screening, we can administer screening instruments over telehealth, and we can use that as an opportunity to not allow for further delays. So if we know that over telehealth, let's say a family is worried about has a speech concern or a gross motor concern, or the family has fallen out of early intervention, we can initiate or refer to early intervention or an autism evaluation via just a telephone call or a telehealth visit. I've done this plenty of times. So that in the terms of telehealth could be beneficial. In terms of correcting for prematurity, when we're thinking about typical development, we often correct for prematurity until the age of 2 in terms of thinking about their developmental age versus their chronologic age. However, in the case of developmental screening tools, we're encouraged to continue at the time points noted. And then just having thoughts about when the highest risk occurs. So with co-occurring, with children with certain genetic syndromes, there's a very high incidence of co-occurring autism spectrum disorder and extreme prematurity as well. In terms of oral health, so we're encouraged to have universal fluoride varnish for children ages 6 months through 5 years. I can speak to my clinic. We've been doing fluoride varnish for about between 8 and 9 years now. It's quick training for providers. And in terms of universal fluoride supplementation, we're supposed to continue discussing that at all of the well visits that are included in the Bright Future. So 6, 9, 12, with this particular recommendation skips the 15-month visit, 18, 24, 30, and then 3 through 16 every year. So what does that mean and who can apply varnish? So I will preface this by this really depends, reimbursement for this and allowance for who does fluoride really depends on your state, your insurance, and your own center. So who can apply fluoride? In the options include dental professionals and physicians, NPs, PAs, and RNs. Again, please refer to your clinic policies, your state policies, insurance-based policies, etc. How often can you apply and when should you start? So you can start after the eruption of the first tooth. So at the 6-month visit or the 9-month visit, depending. And sometimes the 12-month visit if there's delayed dentition or slight delay, and then every 3 to 6 months. So this is debatable. I understand that we can do 4 times a year on top of their 2 regular dental visits. The recommendation is at least every 6 months. And then that's why the star exists there. And then up to the 5th birthday. So the reason the star exists there is, again, this is dependent on your Medicaid versus private insurers and state. So in my state, once the 5th birthday hits, we are not reimbursed for Medicaid for fluoride. And my understanding is that there are some private insurers that will cover fluoride up to the 6th birthday. So many considerations for oral health and CMC. So, and all of my considerations are, I'm sure that each of you could tell me 3 more, or more than that, but I wanted to highlight some that I thought were important. In this population, children are more vulnerable to the effects of oral disease, so they may be immunocompromised, they might have certain cardiac, kidney, hepatic conditions. Many have difficulty maintaining oral hygiene because of developmental conditions, cognitive disabilities, neuromuscular conditions. There's a lot of refusal for oral hygiene, difficulty with parents being able to assist children with oral hygiene because of agitation, aggression, etc., sensitivity. And then G-tube dependent youth who do not orally feed are a subset of this population where there's a thought about should we hold fluoride varnish in this population, because G-tube dependent youth who do not orally feed have a different flora. So they have a different bacterial mix. And in addition, they have their own kind of plaques that they build up with calluses, and the application of fluoride varnish might actually create more of a plaque and callus and might change the flora that they already have, thereby potentially changing their oral bacterial load. And we could go on about this on a different lecture. So there is some, I think it depends on the dental group and the institution, whether they would consider the pediatric group doing this in the office or not for that subset of children. But in terms of children who may eat by mouth or have some supplementation by food or liquid supplementation by mouth, Thinking about the G-tube feeds and flushes, so that can be with a formula can be mixed with fluoridated water, or a family might want, family might be using well water, sterile water, or something else. So you have to think about making sure they're supplementing with fluoride otherwise. And then studies about ketogenic diet, and in that diet, can we fluoride supplement? And my understanding is yes. Other special considerations. So there was there was a major lack of access to dental visits in the beginning of the COVID-19 pandemic, and then subsequent fear and delay of care, because it's of course a place where masks are not worn. And though many of our CMC are not the best with wearing masks because of their different conditions, this is a place where they're particularly vulnerable without a mask in the eyes of parents. And then scheduling challenges, because now everybody feels a little bit more comfortable to go to the dentist. I know in my institution, it's almost impossible to get a appointment now because of the kind of the influx of everyone wanting dental care now. So, and I don't know if that's true of others institutions, but the delayed dental care then can cause worsening dentition, which can cause chronic pain and an increase in agitation, increase in oral secretions, poor oral intake, subsequent weight loss, and increased infection risk. So there's a lot of downstream effects. And we will get to this more in the case that I will present today. And the need for dental care under anesthesia requires multiple clearances, visits, and preoperative COVID testing, which is a lot of care coordination. And then there's also a subset of patients that may not trust or fear their local water supply, which may decrease the fluoride supplementation in their children. So one plug is for institutions that can pull this off is to try to have dental under anesthesia in the patients that are not able to tolerate in-office dental care. This allows for a lot of other care while under anesthesia, particularly for patients who are needle phobic, either aggressive, agitated, or completely phobic. They can receive vaccines and lab draws under anesthesia. Those who cannot cooperate for certain screenings and assessments can have those under anesthesia. This includes, but is not limited to, because I've heard of many other things done under anesthesia, but audiology exams, such as an ABR, ophthalmologic exams with dilation, gynecologic exams, ear exams, cerumen debridement, EKG, echo, etc., x-rays, other studies. Now we're going to switch to depression screening. So we are asked to screen for maternal depression at the 1, 2, 4, and 6 month visits. Often our CMC population may not present for their first pediatric outpatient visit until the 9-month visit if they had a long NICU stay, let's say. So when do we screen in these visits? Well, we know that our families have increased stressors given a potential prolonged NICU stay, they have a child with medical complexity, so there may be differences in bonding, there may be grief involved, there may be prolonged depressive symptoms, in terms of maternal depression by definition, up to 12 months, but maybe the definition is skewed longer here, or are we dealing with maternal depression? Are we dealing with situational depression? I will not purport to be a psychiatrist, but I'm thinking about the families I've taken care of in the last 12 years and what they've dealt with. And, many do have prolonged depressive symptoms, and we should be thinking about how to support our parents too. Regression at times in teen moms, just a comment about sometimes teen moms of children with medical complexity and or extreme prematurity may regress themselves developmentally. In terms of depression screening of the patient in front of you, depression screening is recommended annually from the 12 to 21-year-old visits. But there's many considerations in the CMC population. What about the cognitive ability of the patient in front of you? Do they understand the questions? Can they answer the questions? Could they answer the questions, but they don't know how to answer them correctly, and you might get the wrong question, the wrong answer? What about variations in communication? Do they need a communication device to be able to communicate with you? and sign language, etc. And then utilizing other measures of functioning. So change in mental status, appetite, sleep, energy, interaction, agitation. Some screening tools recommended in this population include, but are not limited to, the PHQ-2, the PHQ-9, the pediatric symptom checklist. Back to depression screening in mothers, some tools that can be used, but are not limited to, the Edinburgh postnatal depression scale, the revised Edinburgh that exists on the SWIC, and the PHQ-2 and the PHQ-9. Again, I'm not endorsing any screening tool, I'm just listing ones that are commonly used. In terms of immunizations, I'm sure we could go on and on about this, also in terms of delayed immunizations during COVID-19, but just some considerations in CMC. So thinking about the catch-up vaccine schedule, the CDC immunization schedule is linked here, and there's a catch-up vaccination schedule to follow. In this population, thinking about vaccine grouping for those with needle phobia, agitation, or aggression. So for example, this is an example I like to use in this population. So HPV vaccine is allowed to be given starting at age 9 in my population. Some populations started at age 11. There are 2 other vaccines, Menactra and Tdap, that are given at age 11. I do have families that say, you know what, I think my child will do better with the agitation and aggression if you do all of those needles in one day. And I think the cell is better if we say, okay, then we'll do the HPV vaccine with the other 2 at age 11. So I've had that happen before, and that's something we can discuss during our discussion, how you approach that. The other thing is, if a child is delayed with vaccines, thinking about every time they step into the hospital for their care, they have a chance to catch up with vaccines. So even if they're not coming in for their scheduled well visit or follow-up in the general peds or children with medical complexity clinic, they have the opportunity, if they come for a specialty visit, to pop over and have to the clinic and have a nurse-only visit to catch them up on vaccines. And we often do that in our clinic. Just sharing some core tools from the Bright, just changing back to Bright Futures, thinking about some core tools in the tool and resource kit, visit questionnaires, pre-visit questionnaires, and parent handouts. The link is included. A couple of screening, open-ended questions, etc., resources, and a shout out to the Bright Futures. Oh, some more resources, and a shout out to Jean and Kathy at Bright Futures. And I think Kathy's on today and very helpful in the chat.